Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. My name is Abdelrafour Houdane, and today we'll be going over the headache session or the headache lecture. Before I start, I know semantics, but my name is Abdelrafour, not Abdelraouf. I know the R is a bit problematic, but it's a ghain, okay? It's a bit of a pet peeve of mine. But al-Muhim, welcome to headaches. Honestly, I feel that this lecture is not very particularly high yield, but I just noticed like you have 88 slides. So it looks much scarier than it actually is. Honest to God, I think it's a very simple session. There are some elements which is low yield, and honestly, I was kind of torn between either making a very high yield session or a very comprehensive session. So kind of like the decision I've come to in the end is this session will be very comprehensive, as in it explains everything that the doctor taught. And I'll probably make a more condensed, smaller version later on, like later on during the week, for someone who wants to maybe, I don't know, cram 2 or 3 days before the final. The general flow of this lecture is going to start with a quick introduction to headaches. Then we're going to move on to the 3 main primary headaches: migraines, cluster, tension, as well as medication overuse headaches. Then we're going to switch and move on more towards the approach, how to approach a patient who's presenting with a headache. And finally, we'll just wrap up with the secondary headaches and questions. We're going to have, like, I think the general theme of PAL is to have multiple checkpoints where you can stop, ask any questions, clarify, stuff like that. There's no such thing as a stupid question, only stupid answers. If you feel like I'm going too fast or I'm speaking too fast, just let me know. I'll try to slow down. And I guess a little bit about myself, right? My name is Abdelrafour. I'm currently an intern at Al Faisal doing my ER rotation. I know what's an intern doing at PAL, but I do like to teach. I like to teach particularly harder topics, but like headaches is also kind of interesting. So without any further ado, let's get cracking. So patient comes in with a headache. This is a very vague symptom. The differential list is huge. A headache is simply just head pain, right? Now, it's always good to kind of like mentally categorize headaches as either being primary or secondary. Secondary headaches usually have an underlying cause, right? Let's say a patient comes in with an intracranial bleed. A lot of times they will present with a headache, but that's really not the chief complaint. Primary headaches, the central underlying cause of the pain is the headache itself. For your knowledge, this lecture really is about primary headaches. Yes, there is a section about secondary headaches, but honestly, you're going to be learning about those other diseases in separate lectures. So really the main content is going to be these 3: migraines, cluster headaches, tension headaches, and a brief mention of medication overuse. Secondary headaches, like I said, the differential list is very long. Infections like meningitis may present with headache, bleeding, intracranial bleeding, masses, increased intracranial pressures, trauma, sinusitis, post-ictal state. All of these can present with a headache, and all of these are also considered as a secondary headache. Now, regardless whether it's primary or secondary, the reason why people feel pain around the head region is activation of small caliber nociceptive neurons. And nociceptive simply means these neurons that detect noxious stimuli, like pain, stuff like that. Now, the big question is, where in brain does stuff hurt? I did not know this before joining med school, but awake brain surgery is a thing. Turns out not all parts of the head lead to pain. So you can kind of classify facial structures into 2 broad categories: either pain insensitive areas, these are areas that simply do not cause pain, and areas which do cause pain. And that's important because it kind of allows us to experience and explore how does pain originate in the first place. Now, parts of the brain that are insensitive, where if you touch them, you fumble with them, they won't cause pain, are stuff like the brain parenchyma itself. The ependyma, right, which is the lining of the ventricles, the choroid, the pia, the arachnoid, the brain cortex, the dura that wraps the cortex of the brain, and the skull itself. These are all areas which technically do not cause pain. Contrast that, on the other hand, with areas which are very sensitive. Now, I'm gonna highlight the first one, big arteries, especially towards the base of the brain. And this is going to become especially relevant when we start moving on to speaking about migraines. Dural arteries in general, central venous sinuses, extracranial structures. These are all different areas which do cause pain because these areas are innervated by the nervous system. Now, when the patient comes in and he's booked in for neurosurgery and they want to be able to, conduct awake brain surgery, the reason why we have to anesthetize the patient, give them lidocaine, etc., is not because of the brain itself. It's because of all these extracranial structures, stuff like the scalp, the periosteum of the skull, because again, these areas are innervated by the sensory neurons. Here's another example of the way how the face is innervated by the trigeminal nerve with its multiple branches, all going towards the trigeminal ganglion, towards the trigeminal nuclei, and up to the brain, where we are able to perceive pain. Again, diagram really looks scary. It's just giving you the innervation of the face. So now the big question, right? What exactly causes headaches? Now, the truth is, no one is really sure. We got a bunch of theories, don't get me wrong, but like no one has a clear, concrete answer of what causes headaches. If we did, we probably would have found like an all-out one gold pill treatment. But unfortunately, it doesn't exist. There are a bunch of theories, and a lot of them have like correlations with different diseases, which we can explore. One big theory is, and I put it on bold, is dilation of major arteries, because this is heavily linked with migraines. Research has shown that also traction in general of major arteries, especially near the skull base, do cause pain. Inflammation of sensitive structures like the sinuses, which are richly innervated, would also lead to pain. Direct pressure or compression of cranial or cervical nerves. Let's say a patient comes in, maybe a 55-year-old, 60-year-old, with a slip disc, a cervical slip disc. This direct compression would present with manifestation of a headache. Alternatively, a patient with trigeminal neuralgia. This is caused by direct compression of the trigeminal nerve, something like a vascular loop. Scalp and neck muscle tightness has been linked to tension headaches. And also pain could be just simply referred pain from an ENT organ, like referred pain from the ear, referred pain from the nose, throat, etc. Now, before we dive in, I just want to kind of give you guys these like clinical scenarios, just to kind of drill in how the three different headaches usually present. Imagine you're at your clinic and a 26-year-old female walks in. She complains of a throbbing left-sided headache, nausea and vomiting. She's experiencing photophobia, happens usually once a month, a few days before her period. And she complains that, oh, her mother and sister also all have similar symptoms. This is a very classical picture of someone presenting with a migraine. Contrast that with a 23-year-old male who's presenting with severe pain around the right eye, literally right behind the eye. His eye is red and teary. He mentions how it happens every October. The pain lasts for like 2 hours, improves, and happens in these like little kind of like frequent episodes. This is a good example of a cluster headache. Finally, a 44-year-old male, let's say he's a consultant neurologist, he's on stroke service, so poor guy is beyond stressed. And now he's complaining of a very classic band-like headache. It's mild, it's annoying, but it's mild. It's not really impairing his activities. And he has no other symptoms. He feels, I don't know, some neck tightness. This is, again, more of a tension headache. Again, the only reason why I'm bringing this up now is to kind of prime you guys for when we re-explore these like clinical case presentations later on. And again, if we begin to compare and contrast على طول, you can notice that each type of migraine has a particular vibe. Migraines, usually throbbing, usually one-sided, either right or left, and heavily associated with nausea and vomiting and photophobia. Cluster headaches, usually periorbital, around the eyes, and important autonomic symptoms. The red eye, the teary eye, the lacrimation, the rhinorrhea, all this is very characteristic of cluster headaches. And finally, tension headaches, bilateral, band-like, and very importantly, no associated symptoms. Again, we're going to kind of go over all this later on in more detail, but this is kind of like the first introduction to the topic. Any questions so far? All right. By the way, is my voice loud and clear? Just making sure, because okay. Nice. Okay, so now, ooh, how do I close chat? 1 second. See, this is literally why I do not like to present in Zoom, but it's okay. So welcome to migraines. Honestly, this is probably like the biggest, the hardest, relatively speaking, because the whole topic is not that hard, honestly. But it's the longest, most complicated subject in this lecture. And most likely, any question that would come up is probably going to be a migraine question, knowing how to do exams. Migraines is very common, and I bet some of us had migraines before, and we can all agree they suck really badly. Migraines really aren't fun. The best way to kind of like figure out what's going on is to see what is the medical definition of a migraine. Now, I hate text, okay, but there is a 5 criteria in order to define a migraine headache. And I think starting with this approach kind of gives us a better idea of what we're dealing with. Now, the first criteria for someone to be diagnosed with migraine is different, as in a diagnosis, is to have at least 5 attacks of what is considered a migraine. And what is considered a migraine? Any headache that fulfills criteria B to E. Criteria B, duration of 4 to 72 hours. Me, I'm a simple guy. I'm gonna be honest. I don't like to remember stuff like that. So I remember 3 hours to 3 days. The general duration of a migraine is from 3 hours to 3 days. Patients should also have 2 of the following 4 characteristics. Number 1, unilateral, very important. Pulsating or throbbing in nature. Having moderate to severe intensity. Guys, migraines suck. No one really has a very mild migraine. It's annoying and really uncomfortable. And finally, a headache that impairs routine physical activity or sometimes triggered by physical activity is very characteristic of a migraine. So in order for someone to be diagnosed with having a migraine, they have to have 2 of the following 4 features. Criteria D is the nausea and vomiting. 90% of patients present with nausea. It is a very, very good way to know that someone has a headache, a migraine. Also, patients usually present with photophobia and phonophobia. When you ask them, like your Socrates, they would mention, oh, I feel better when I'm in a dark room. And once you start rotating in hospitals, if you start taking history from someone with a migraine, they will ask you, can you please switch off the light? It's very bothersome. Phonophobia, some patients have irritability when listening to sounds, so they prefer to be in a very quiet area. Again, very characteristic of migraines. Finally, no other diagnosis is more likely. If a patient is coming into you with a unilateral throbbing headache, okay, that's been there for maybe 6 hours, and he also mentions that he had a huge car accident 4 hours ago, it's probably brain trauma. In order for you to diagnose someone with migraine, there have to be no other possible kind of alternative diagnosis. This is a very classical theme in many diagnostic criteria, just something you should know, that if something is more like obvious, if a patient is presenting with stroke-like symptoms, it's probably not a migraine, even if it fulfills the previous criteria. Now, a lot of times we can kind of differentiate migraines as either having aura or without aura. I'm just telling you this now. We're going to explore it later on when I start introducing the concept of auras. Now, let's take a little simple graph, right? Let's say on the x-axis, we have time. On the y-axis, we have symptoms intensity. Patients with migraines obviously have a headache, right? They start feeling a headache after a certain point. It increases in intensity, plateaus for a bit, and then begins to decrease. And around a similar time frame, you also have the associated symptoms. Because migraines, unlike maybe a tension headache, usually do not present with headaches alone. They're going to have the nausea, the vomiting, the photophobia, and the phonophobia. Now, I don't know if you guys are aware of the concept of a prodrome. A prodrome is simply a group of manifestation features, symptoms that are very mild and usually happen before the onset of the main symptom. For example, one of the prodromes of COVID-19 is a loss of taste. You feel fine, you just have a loss of taste. Then you get the symptoms later on. Another example of a prodrome is patients who have herpes zoster, right? Before they have like the dermatomal rash, they usually will have a prodrome of paresthesia, viral illness, weakness, fatigue, then they get the actual manifestations. Migraines are no exception. Migraine prodromes are very, very varied, and it really depends. Some patients present with mood changes, irritability, depression, sleep, apathy, neurological symptoms like yawning, photophobia, phonophobia, vision changes. I know, it's in red for a reason. Constitutional symptoms, fatigue, pallor, fluid retention, muscle weakness, muscle pain, hunger. It's a wide variety of different prodromes. Vision changes is an example of an aura. Not all patients with migraines have aura, but some patients do present. So what is an aura? An aura is a subtype of a prodrome, right? It is a warning sign before the onset of a migraine that is usually visual. So these patients will be walking around having, I don't know, a regular ass day, and then suddenly they start noticing these visual disturbances, scattered lines, scotomas, their field of vision begins to change. This is an example of an aura. And these patients know that within a few hours or an hour, they are going to develop a migraine. So this is what some patients have. It usually, again, precedes immediately the symptoms. Also, after resolution of symptoms, a lot of patients have a postdrome, drowsiness, sometimes depression, difficulty in concentration and memory that happens after the headache and the associated symptoms resolved. Now, a lot of times with migraines, there's some sort of trigger that initiates this whole kind of process. Now, because migraines are very varied, no two people, there's no set definition of a certain trigger. People can have very, very different types of triggers. Some people are triggered by strong odors, some by stress, some certain periods of time before their menstrual cycle or after their menstrual cycle or mid-cycle, some maybe with caffeine, lifestyle changes, sunlight. Some people, certain weather triggers their migraine. Again, like a lot of neurological diseases, we kind of don't know why. We've noticed that they exist, but no reason why. Now, this is a classical migraine, right? I do want to introduce some rarer types of migraines. This is very, very low yield, but it's mentioned in your slides, so I'm a teacher. One thing is migraines with brainstem aura. Most patients who have migraines with aura have visual symptoms. Some patients do not have visual symptoms, they have brainstem symptoms, dysarthria, vertigo, ataxia. So initially, as a doctor, you think, is this patient having a stroke? But after you do the full workup, you realize, no, there's no actual motor weakness. There's no lesion on the brain. It's just the aura they have before getting a migraine. Another type of migraine is the ophthalmoplegic migraines. They usually present with oculomotor dysfunction, ptosis. The cranial nerve 3 is kind of affected. No one knows why. It's very transient and improves with time, but that's just like a rarer subtype that you should be aware of. Now, some patients have chronic migraine, as in this migraine goes on for years. It's not like a once in a year thing. It's very, very common. And again, a lot of scientists and doctors are trying to figure out the causes of chronic migraines because it places a lot of burden on the patient's health. Again, it's neurology. It's a lot of theories. It's a very I don't know how to describe this, but the field, there's not a lot of well-known, accepted understandings for a lot of disease processes. One theory is this concept of central sensitization. Each time you have a migraine, and we're going to speak about this once we go over the pathogenesis, consider there is a certain element of neuroinflammation. This neuroinflammation makes getting another migraine much more common, much more likely. The central nervous system has been sensitized to getting another migraine. So these patients, that's one kind of theory of why patients have chronic migraine. Another theory is the CNS pain modulation system. And again, I'll be honest, this is so low yield that before today, I have never heard of this pain modulation system. I know, it's annoying, but I'll go over it and try to explain it as best as I can. The concept here of the pain modulation system is that in the midbrain, there is a region around the cerebral aqueduct called the periaqueductal gray matter. This periaqueductal gray matter communicates with something called, the rostral ventromedial medulla. And it's called pain modulation because the concept here is when your cortex feels pain from whatever source or whatever cause, it sends a nervous impulse to this pain modulation system to control it in order for your brain to be able to detect and kind of like sense and suppress it kind of. Now, when a patient takes analgesics normally in an acute setting, this will go to the rostroventromedial of medulla and kind of like make it work better in terms of inhibiting pain. So these patients will feel less pain. However, let's say a patient has been taking these analgesics for a long period of time. They've been taking them chronically. In this setting, the exact opposite thing happens. Chronic analgesics will actually inhibit the rostroventromedial medulla, and patients will begin to feel more pain. Also, emotional factors, stress, same kind of concept. It has been linked to kind of inhibiting the pain modulating system. So these patients feel more pain. And that kind of makes sense. When you're feeling stressed or when you're under like emotional settings, you feel like, I don't know how to describe it, but me anecdotally, I feel that pain hurts much more than if I was healthy and I was in a good like mood or vibe. So this is kind of like the concept of the pain modulating system. This is from the slides. And the reason why it's relevant is because it ties in with the concept of patients who have chronic migraines secondary to medication overuse. This idea that giving a patient too much analgesics may kind of counterintuitively impact the pain modulating system. But again, it's the periaqueductal gray matter which interacts with the cortex, and this is kind of like the system. So that's quick introduction to migraines, how they present. We're going to move on to the next stage, which is the pathogenesis of migraines and the management. So again, any questions at this stage? Okay, now we move on to the fun part, right? The pathogenesis. It's a bit confusing, but inshallah, hopefully, things get a bit clearer. The short answer is, honestly, no one really knows. It's neuro. No one knows anything. So what they do know is activation of meningeal nociceptors leads to pain. So receptors at the level of the meninges are able to kind of feel pain. If they get triggered, the patient will feel pain. Previously, it was believed that the dilation of intracranial blood vessels, in particular the ones in the dura, lead to migraines. Now, the theory kind of has changed. Dilation is very important in the pathogenesis, but there is something that happens before that that leads to the dilation. Previously, it was thought that dilation itself was the primary cause of headaches. This has been disproven in recent times. So, the central cause, that no one knows why, some sort of hyperexcitability in the brain happens, leading to artery dilation. Why is there hyperexcitability? What exactly happens in the brain? This is unknown. So you have some sort of CNS problem, something kind of happens, right? And then you have activation of the meningeal receptors, and you have pain. What is that middle step? This is where kind of the receptors and the serotonin and the CGRP all come in. The idea here is, let's say for some reason, the brain is hyperexcitable. This will go down to the trigeminal nuclei, and they will synapse with the rest of the trigeminal system to go to the ganglion, go all the way down to the dural arteries, release serotonin, release CGRP, and cause dilation. This dilation of blood vessels will then eventually lead to meningeal nociceptors being activated and pain. Now, why do we care? In general, doctors care about pathogenesis really to be able to discover better treatment. So knowing this kind of concept, we know maybe hypothetically, if we block that synapses that happen at the level of the trigeminal nuclei to the ganglion, or if we block the synapses between the blood vessel and the neurons, hypothetically, no dilation should happen, thus no migraines. And this is exactly what they discovered. So two kind of receptors are involved in migraines, serotonin as one and CGRP as the other. Now, in this picture, you can see a dural blood vessel and a synapse on it. On the synapse, on the neuron itself, is something called a 5-HT1D receptor. 5-HT1 is the fancy schmancy name of serotonin. So you have a serotonin D receptor on the neuron, a serotonin B receptor on the blood vessel. If any of these basically, if once the synapse occurs, that blood vessel will dilate. So we actually have a third serotonin receptor. It's just not on this diagram. But like again, the serotonin 1B is on the blood vessel. The serotonin 1D is on the peripheral neuron. And at that level of communication between the trigeminal nuclei and the trigeminal nerve is a serotonin 1F. And again, why do we care? Because again, hypothetically, if I blocked any of these receptors, no dilation should happen, and thus a migraine would be treated. So exactly, this is just a repeat of that same slide. You can see on the right-hand side, you have the 1F receptors at C1, C2, and you have the 1D at the peripheral neuron and the 1B at the blood vessel. That's exactly what happened. They found out by a group of medications called triptans and ergots, which are basically serotonin 1B and 1D agonists. If a patient receives triptans or ergots, the pain of a migraine improves, proving that there is some sort of role of these receptors in migraine pathogenesis. And now, recently, a new class of medications has come into the market. They call them GPANs, or serotonin 1F agonist. And we said these agonists are at the level of the central neuron. And again, same concept happens. You block those receptors, there will be no impulse towards the dural arteries, no dilation, thus no pain. That was the concept of serotonin receptors in migraine pathogenesis. We also have something called CGRP. CGRP stands for calcitonin gene-related peptide. These are a group of peptides, amino acids, that lead to vasodilation, right, of dural blood vessels, intracranial blood vessels. Initially, the correlation between CGRP and migraine was noticed when patients with migraine had elevated levels of CGRP in serum and saliva. So they infused these migraine patients with CGRP, and again, that induced a migraine. So that kind of role was kind of confirmed through these kind of experiments. Triptan treatments, treating people with triptans, not only works via the serotonin pathway, but has been shown to normalize the levels of CGRP. CGRP, same concept. That synaptic neuron will release this peptide. It will bind to the blood vessel, lead to dural artery dilation. This dilation will lead to meningeal irritation. And again, you have the classic migraine headache. And one kind of like mnemonic, one way I remember that the relationship between dural artery dilation and migraines is that patients will present with a throbbing headache, kind of very similar to how an artery throbs in each pulse. So again, in conclusion, you have a CNS problem, which we do not know, but some sort of hyperexcitability that will go down into the trigeminal nuclei. From there, they will synapse across the serotonin 1F receptor. This will then go towards the trigeminal ganglion, synapse either at the blood vessel by 1D, 1B receptors, or using the CGRP pathway. Both of these kind of pathways will lead to the same thing, dilation of the dural blood vessel. This dilation will lead to the meningeal receptors being activated, and the patient will present with pain. I'm going to put like a little cheeky checkpoint here, just because pathogenesis is very confusing. Does anyone have any questions? Yeah, technically, like it's not 100%. It's still a theory. There's a lot of like counter arguments for all of them. That's the thing with neurology, to be honest. Okay, listen, I'm not hating on neurology. It's not the brain and the nervous system is not my favorite organ. I hate the kidneys more, to be fair. It's not as amazing as something like the bone, simple, beautiful organ. But at the end of the day, yeah, it's simply a theory because, oh yeah, sure. 1 second. Let me go back to. So, going all the way back, at the level of a blood vessel, you have a serotonin 1B receptor that's sitting on the blood vessel itself. If serotonin binds to that receptor, it will basically lead to dilation of that artery, because serotonin is a dilator. At the level of a neuron, you also have a serotonin 1D receptor at the level of the peripheral neuron. Serotonin, whenever it's released, will lead to dilation. Finally, the third receptor is at the level of the trigeminal nucleus synapsing with the trigeminal nerves. At that level, you have the 1F receptor. The concept here is serotonin is a dilator. For some reason, we do not know why serotonin is being released. We just know that it does. And when it does, it will eventually lead to migraines via the dilation of the arteries. So the concept here is that we can block any of these three, and both of them will all lead to preventing the dilation from happening in the first place. If I block the blood vessel, it won't dilate. If I block the peripheral neuron, it won't release serotonin to cause dilation. And if I block the central neuron serotonin receptor, it won't even reach the level of the synapse between blood vessel and peripheral neuron. Does that make sense? Or do you want to go over how the medications prevent? Oh, okay. So yeah, again, still very theoretical. No one kind of has 100% confirmation that this is the way how it works. We know that giving a patient a serotonin agonist, a receptor agonist, or preventing serotonin from being released improves migraines. So we know that this mechanism kind of happens, but again, it's still at the end of the day just a theory. Moving on to now treatment. And the only reason why we care so much about the pathogenesis is to be able to give patients proper treatment, right? Now, there's three kinds of treatments for any patient with migraines. Number one is lifestyle. Migraines are usually triggered by a trigger. So trigger avoidance is very important. Then you have two types of treatment, abortive and prophylactic. Concept here is abortive treatment is for a patient who is presenting with the headache acutely. This patient is in pain, it's not responding to Panadol or paracetamol, you want to be able to give her or he something to abort the attack. Prophylactic is for patients who have frequent headaches. They take it chronically to prevent a migraine from happening in the first place. Trigger avoidance is very important. Prevention is better than the cure. Smoking cessation, very important for smokers. Avoiding triggers, so patients who get triggered by tyramine, nitrates, monosodium glutamate, limiting caffeine and chocolate, avoiding sleep deprivation, maintaining regular sleep and meal schedules. All these are examples of triggers that could be avoided to prevent a migraine. Acutely, though, patient comes in with an acute attack. You usually will begin first with the simple, right? You always start with the simplest thing, acetaminophen, Panadol. That doesn't work, you can bump them up to NSAIDs. If NSAIDs don't work, we can give them triptans and ergots, which we're going to go over later on. And if this doesn't work, CGRP antagonists are this new line of treatment. But don't forget, patients with migraines are not only presenting with headaches, they're also presenting with nausea and vomiting. Very important to also tackle that. Give these patients metoclopramide, ondansetron. These are known antiemetics that can be given. So let's speak about triptans and ergots. These are two types of medications, classes of medications that work by acting as a receptor agonist. Which receptors in particular? The serotonin 1B that is on the blood vessel and serotonin 1D that is on the peripheral neuron. By blocking these receptors, you prevent the artery from dilating. So these are very good vasoconstrictors. Because they are vasoconstrictors, you do not want to give them to a patient who has coronary artery disease, a patient with, for example, cerebrovascular disease, or a patient with peripheral vascular disease, or a smoker plus taking oral contraceptives, or any patient with severe hypertension. This vasoconstriction, yes, it will abort the migraine, but it's going to cause much, much more serious problems. Geptans are the new medications. These are the ones that basically are CGRP antagonists. They are monoclonal antibodies, so they all end with the UMAB suffix, and they either work by targeting the CGRP receptor or they target the CGRP ligand itself. They're all used to treat migraines, both episodic and chronic, but there is one particular type that is called galcanezumab. This is also used in the treatment of cluster headaches. So again, that was the abortive treatment, right? We also have a prophylactic treatment, but not all patients with migraine are given prophylactics. It's a certain subset of patients who are eligible to get prophylactic treatment. These are patients who get more than 2 migraines per month, or patients who get migraines that last for several days. Having a migraine that lasts 6 hours is annoying, but tolerable. Having a migraine that lasts 3 days will have significant impairment in your life. Any patient who have extremely severe symptoms, or patients who, for example, cannot receive abortive therapies, patients with coronary artery disease, for example, patients with cerebrovascular disease, for example, you cannot give them the abortive therapies. So these patients are eligible for receiving prophylactic treatments. And there's a huge array of prophylactic treatments. Seizure medications can be given: topiramate, valproate, gabapentin. Some blood pressure medications can be given, like propranolol, calcium channel blockers like nifedipine, antidepressants, SSRIs, SNRIs. All of these have been used in the successful prophylactic treatment of migraines. There are new medications on the market, new approaches. One of them, as I said before, the CGRP antagonist injectables. By the way, monoclonal antibodies in general are always given subcutaneously. So these are injectables. You also have Botox, which is a bit surprising, but Botox can be given in particular patterns, and you got to give it once every 3 months, once every 4 months. So it's not like a one-time fix-all solution. These patients will have to keep coming back to the headache clinic, receive their Botox, and it does help prevent migraines. Why? I am not particularly sure. But that kind of like sums up migraines and sums up the management of migraines, whether it's abortive, whether prophylactic. Okay, low termine diet. So there are some certain foods which have high levels of termine. Examples of that are going to be some hard cheeses like Parmesan, cheddar, I believe. These kind of like foods have an amino acid called termine. There are some certain medications, I believe MOA inhibitors, which is contraindicated to have termine because they can have a very lethal kind of side effect. Patients with migraines, some of them are triggered by termine in their diet. So putting a patient on a low termine diet prevents them from developing, it's because technically it's a trigger. So that's the idea of having a low termine diet. Same thing with monosodium glutamate, seen a lot in Chinese food. That could be a trigger for some patients. So there. Honestly, I don't know why Botox helps with migraines. I'll be honest with you. I'll do some research for you and I'll get back to you later on. There's my number at the bottom. So we could see that. I'll get back to you on this one. Are CGRP antagonists considered for both abortive and prophylactic treatment? Yes, they are. The truth is CGRP antagonists are very, very new. They recently got FDA approved. So right now, there's a lot of research ongoing determining whether they're better in abortive, whether they're better in prophylactic. But technically nowadays, they are given in both. Time will tell if maybe they might realize that there's no benefit giving them for abortive treatment. But at the moment, they can be given as both abortive and as prophylactic treatment. Okay, so finally, we're done with migraines. The rest is inshallah, smooth sailing from here. So firstly, we have cluster headaches. Now, we go back and revisit the previous case that we had earlier. 23-year-old male comes into the clinic with severe pain around the right eye. The right eye is red. The right eye is teary. He's like, there's like, rhinorrhea. It tells you that it happens every single October at the same time and lasts for maximum a day. This is a classical clinical picture of a patient with a cluster headache. I mentioned male because it's important in this case. Migraines are much more common in females. Cluster headaches is the exact opposite. The ratio of males to females is actually 6:1. Patients with cluster headaches present with a unilateral pain that is usually periorbital or temporal. Patients with migraines usually have half the face affected. These are much more restricted. They come in clusters of 1 to 6 per day, and they can last from 15 minutes to 3 hours. And ala طول, you can tell the difference between cluster headaches and migraines just based on duration. The duration of migraines usually is minimum 4 hours, 3 hours. Here is the exact opposite. Short headaches, really intense, very sharp pain that improves but comes in clusters. Another very important clue for you to figure out if your question stem has a cluster headache is the presence of autonomic symptoms. Very important. These patients will present with conjunctival injection. Now, conjunctival injection is just a fancy way of saying red eyes. Miosis, ptosis, lacrimation, rhinorrhea. These are all autonomic symptoms that are heavily associated with a cluster headache. Interestingly, REM sleep are a trigger for a cluster headache. Why is that relevant? Because a lot of time these patients will go to sleep, go to sleep fine, and like mid-sleep they'll wake up with this severe pain. This is because the REM sleep itself can be a trigger for these patients. Pathogenesis, who knows? No one really knows for sure. The current prevailing theory is that it is caused by ipsilateral posterior hypothalamus activation. And this is proven by functional MRI studies, which show that in the patient who is ongoing a cluster headache, the posterior hypothalamus is activated, as well as the ipsilateral mesofrontal cortex. This diagram is in the lectures, just goes to show that last time, compared to migraines, the sphenopalatine ganglion is affected, which explains why these patients present with these autonomic symptoms. Migraines do not. Migraines, their associated symptoms are nausea, vomiting, photophobia, phonophobia. Now, treatment of cluster headaches are again either abortive or prophylactic. And you also have bridge therapy, which is just steroids, very low yield, just ignore it. In terms of abortive therapy for a cluster headache, the most important thing is oxygen. Very weird, actually, surprisingly, but oxygen has been shown, 100% oxygen has been shown to be a very good abortive agent for any patient who comes in with cluster headache. You could put the patient on high flow oxygen, 15-20 minutes, he feels much better. This is a very classic step 1, step 2 question. They love to bring us patient with this kind of classic headache. They ask you what's the next best step. The answer is put the patient on high flow oxygen. Preventative for patients who have maybe, for example, repeated cluster headaches. And a lot of these patients, because it's so severe, they live in fear of getting their next cluster. So again, very similar to migraines, there's a bunch of medications. No one really knows what's the gold standard. So verapamil can be given, topiramate can be given, lithium can be given. And also on the top, you have these new fancy FDA recently approved medications. One of them was galcanezumab. And I spoke about this earlier. I spoke about how one of the CGRP antagonists can be given in this case, and that is galcanezumab. Non-invasive vagal nerve stimulation is another kind of newly FDA-approved treatment to kind of prevent cluster headaches. Now, let's quickly move on to tension headaches. I think practically all of us had a tension headache at some point. It is the most common headache of all time. And again, same case scenario, 44-year-old guy comes in with clearly high levels of stress. And you guys are second years. Let me tell you something. There is nothing more stressful than being on stroke service. That is so mentally exhausting. The hours are bad. The stress is insane. So that's why I put in that little questions, like little clue in the question stem. Anyway, al-muhim, band-like headache, very classic of a tension headache. These are usually 30 minutes to 7 days in duration. They're painful, and the way how they present, they need to have two of the following. The pain is either pressing or tight pain, like a tight band around someone's head. Contrast that with the sharp pain of cluster headaches and the throbbing pain of migraines. The pain is mild to moderate. It's annoying. It's not really function impairing, but it's annoying, usually bilateral, and it's not made worse by routine activity. And also very important, these patients do not have associated symptoms. They do not present with vomiting. They do not present with nausea or photophobia or phonophobia. This is more classic of migraines. Treatment of tension headaches are very simple. On the acute term, we can give patients acetaminophen, NSAIDs, muscle relaxants. If a patient has chronic tension headache, physical therapy is very important. A lot of times, the tight neck muscles, patients who are undergoing stressful situations may contribute to chronic headaches. And also like tricyclic antidepressants have been shown to help in patients with chronic tension headaches. One more thing, medication overuse. We briefly kind of went through this early on when we were speaking about the pain modulation system. Now, medication headaches, also known as the rebound headache, occurs in patients who have been taking pain analgesics for a long period of time. This is a headache that is usually mild to moderate, that is present for over 15 days per month. usually happens after a patient has been overusing a medication for over 3 months, for example. And the cause, again, is not really certain. Theories that have been pushed over the years was chronically low serotonin, elevated CGRP, or that concept of central sensitization, where because if you have this chronic intake of analgesics, the pain modulation system is not as good as before, so they begin to have rebound headaches. Again, not really a very low yield. I think in all of step 2 UWorld, there was literally one question of medication overuse, but just something that you should keep in the back of your head. And one more thing, what does overuse mean? It really depends on the exact type of medication. Simple analgesics, taking them for 15 or more days per month, that is considered overuse. Combination pain relievers, for example, caffeine plus aspirin, caffeine plus acetaminophen, 10 or more days per month. Prescription migraine medications like triptans and ergots, taking them for 10 or more days per month is considered overuse, and opioids, 10 or more days per month. Very, very low yield slide, just putting it there for the sake of completion. And that is now the 5th checkpoint. Does anyone have any questions so far? I know we kind of jumped through 3 or 4 quick topics. So let's see. Okay, good question. Do we put them on oxygen as it's something to do with the vessels behind the eyes? Do we need to know the reason why oxygen works? Honestly, at your level, and even to the point of, I think, maybe until you reach, unless you want to become a neurologist, knowing why is not really relevant. I'm sure there is some theories why oxygen works. I personally do not know why. I just know that one of the management options for cluster headaches is high flow oxygen. For some reason, it works. I'll check for you if you want. I'll get back to you later on why it works, maybe some theories behind that. But at the moment, I have no idea why it works. Just, it's apparently a thing. Any other questions? Okay. Moving on, we're nearly done. Okay. Now, patient comes into your clinic. How do you approach such a patient? If I had to summarize medicine in a single slide, like clinical medicine in a single slide, it's probably this one. Any patient for any complaint, your structure is always going to be history plus physical examination. That will help you generate a long list of differentials, right? And then you will do imaging and labs to kind of rule in and rule out. I know as second years, this is like your first real block of clinical medicine. But the more time you spend like learning about medicine, the more time you spend in 4th and 5th year rotating in hospitals, and then later on, once you start becoming an intern, you realize that history plus physical will give you 90% of the diagnosis. Imaging and labs will just confirm or like kind of like guide management. So any patient with a headache, you want to have a differentialist in mind. Taking history will begin to narrow down that differential, and physical examination will begin to kind of like rule out and rule in more other stuff. Then you will choose your imaging and labs accordingly. When you're taking history for any patient, there's always this concept of red flags in any chief complaint, whether it's headache, whether it's abdominal pain, whether it's chest pain. And it is important to know these red flags to be able to determine whether there's something much more serious going on. For example, if a patient comes to you with chest pain and you take history and they tell you, oh, I also had loss of consciousness, that's a huge red flag. Compare that with someone who's coming in with chest pain and tells you, oh, but I had like a punch to the chest. Nafs al-shay with headaches. There are certain symptoms and certain clues in history which will make you really concerned that the headache is not a simple migraine or a simple cluster headache or a simple tension headache. It could be something serious. The thing about headaches is that the differentialist is huge. It could be a tension headache, it could be a stroke, it could be an intracranial bleed. You do not know. So knowing the red flags are very, very important. Now, what are some examples of red flags? The first one is sudden onset. Headache that came suddenly out of the blue is worrying compared to a more slowly progressing, I was feeling bad for a few hours and it was getting worse. Another example is a new onset headache in someone over the age of 50. Older people usually, The bar for being kind of like scared is much lower. Patients who have, for example, HIV and cancer, or risk factors for those two. Why is this relevant? Imagine a patient comes in, 29-year-old patient with leukemia. She's being followed up by oncology and now presenting for a headache for the past week. That is worrying. There is this concern, could it be brain metastasis? So this is a red flag. Same thing for HIV. HIV, for you guys' information, is a very immunosuppressive state. There's a lot of neurological infectious disease that only occur in patients who have HIV once their white blood cells drop below a certain number. Systemic illnesses. A patient with headache and nothing else, it's okay. A patient with headache plus fever and neck rigidity, now I'm concerned about meningitis. Altered mental status, focal neurological deficits. These are both examples of red flags. Papilledema, I'm going to go over this later on, but that's a sign that there is an increase in the intracranial pressure. And head trauma, that is also a very worrying red flag. And again, as you guys study more neuro, as you guys begin to know more of those neurological diseases, you will intuitively begin to appreciate these red flags without even having to think. Moving on to taking history. So patient comes in with headache. Socrates, amazing. You go through the Socrates system. The site, is it unilateral? Is it bilateral? Is it like a tension headache, like a band-like pattern? Is it under the eye? When did it start? Were you doing anything in particular? The character, is it a sharp pain? Is it a throbbing pain? Is it a like pressure-like pain? And على طول, straight away, you're beginning to eliminate and differentiate between different causes. Associated symptoms, very important. You want to be asking about nausea. You want to be asking about photophobia, phonophobia, stuff like that. Lacrimation, redness of the eyes. You want to be asking about precipitating factors because that's very important when you are going to be teaching the patients trigger management, how to avoid triggers. How will you tell the patient to avoid triggers if the patient themselves do not know what their trigger is? Medical history is important. Past surgical, again, could be a red flag. Patient who is a known case of methadone HIV, you're going to be taking headaches a bit more seriously. Medication history is important. Again, medication overuse headache is a thing. Travel history is important for like infectious diseases like meningitis, recent cave explorations, blah, blah, blah. So your diagnostic steps, so after you've done your history, you've done your physical, your diagnostics is going to be based on your differentials. So let's say, for example, I am worried about an intracranial mass, or I'm worried about an intracranial bleed, or I'm worried about trauma. I'm probably going to ask for a CT brain. And I'm currently rotating in ER. I cannot tell you the amount of times I order CT brain per shift. It is the bar for ordering a CT brain is very low when you want to rule out serious pathology. Lumbar puncture, patient presenting with a headache plus fever plus neck rigidity. I'm really concerned about meningitis. I want to do an LP. MRI, MRA, angiography, have their own reasons based if I'm suspecting maybe an intracranial mass, or if I want to do, for example, ESR and CRP, if I'm suspecting temporal arteritis, stuff like that. So again, this is really based on your history and based on your physical examination. Any questions so far? Now, the thing about secondary headaches, okay, is that, let me go find play. The thing about secondary headaches, honestly, all the diseases are stuff that you've already are going to study from other lectures. You are going to go and study meningitis in detail. Yes, one of the symptoms of meningitis is a headache. That is why it's a secondary headache. But what I'm going to do now, more just to kind of wrap things up, is to go over basically these little kind of like snapshots. I did not do, this is not an exhaustive list of all secondary headaches. You'll see them in other lectures, but I just want to kind of give you something just for the sake of completion. Increased intracranial pressure. Characteristics type of headache. They will tell you their headache is worse in the morning because aslan, the intracranial pressure is usually higher in the morning. And they will have positional headaches. It's worse, for example, when they're bending forwards. And another huge flag is a patient, especially a child, who's presenting with a headache plus a lot of nausea and vomiting, especially if they tell you my nausea is worse in the morning. على طول, when you see these kind of constellation of symptoms, you want to do something called a dilated fundoscopy. You're going to be looking through the eye at the optic disc. Now, if a patient has something called papilledema, and I'm going to describe it now, that's a very, very high red flag. This patient has increased intracranial pressure, and you want to do some sort of imaging. CT brain, you want to see, is there a space occupying lesion in the brain? Now, the image on the top is an image of a normal retina, the normal optic disc. Notice how it is flat. It's nice, it's crisp. On the one in the bottom, it feels like it's coming out of the screen towards you. There is something called blurring of that optic disc margin. If I told you to draw a line around the optic disc, it's hard to tell where it really ends and starts. This is a very characteristic sign of increased intracranial pressure. And by around fifth year, I know it feels very far away. When you do ophthalmology, you're going to be very, very used to the concept of optic disc blurring. Next, hypertension headaches. Usually, hypertension is asymptomatic. However, at very, very high levels of high blood pressures, patients may present with a headache. Usually, it is a bilateral throbbing pain that is worse with activity. Now, if a patient is pregnant or she's postpartum and she's presenting with hypertension headache, I am, as a physician, very concerned because this could be a warning sign this patient is going into eclampsia. I do not think you guys took OB-GYN yet, so do not worry about this now. Just know that eclampsia is a feared complication of hypertension during pregnancy. If a patient comes to you with episodic headaches and anxiety and sweating that happens all at the same time, this could be a sign that this patient could have something called a pheochromocytoma. Pheochromocytoma is this catecholamine-releasing adrenal tumor, releases a bunch of catecholamines. And one of the side effects is this episodic headache. Again, hypertension headaches, we usually want to take it seriously because if untreated, it can eventually turn and develop into something called hypertensive encephalopathy, which is going to be hypertension plus altered mental status, etc. Meningitis. Patient comes in with a severe headache, neck rigidity, systemic symptoms, maybe fever, maybe a rash if it's meningococcal. على طول, you are concerned that this could be meningitis. What do you want to do? Do a lumbar puncture, do a gram stain, see if this patient has changes in CSF. And you guys should be taking a meningitis lecture at some point. You guys should be really good at being able to tell what kind of infection someone has based on the CSF values. This is a very, very classical step 1 question. It's also a very classical step 2 question. You should be very comfortable with CSF interpretation. Again, when you're taking your history, if this patient had a recent travel to maybe Africa or to a place which has high endemic status of meningococcus or meningitis causing bacteria, that would make you kind of begin to think and query of meningitis. Subarachnoid hemorrhage, usually an older patient who is coming in with this sudden onset, worst headache of their life, very, very characteristic kind of appearance. You do a CT scan, you'll see this classic sign of subarachnoid hemorrhage. Of course, I'm sure that you guys are going to take this later on. When you do a lumbar puncture, acutely, you'll see RBCs. Later on, you'll see something called xanthochromia. For these patients, family history is very, very important. Past medical history is very important. If a patient comes in, tells you family history of sudden death via aneurysm rupture, could be something to bear in mind. Past medical, if patient, for example, known case of polycystic kidney disease, subarachnoid hemorrhage is something to bear in mind. Finally, temporal arteritis. If a patient comes in, usually elderly patient with a temporal headache plus scalp tenderness. Scalp tenderness plus headache is not a nice combination. Headache doesn't usually present with scalp tenderness. So the moment you see this combination of factors, especially if there is jaw claudication, you do not wait. You give this patient corticosteroids straight away. You don't even do diagnostic test. You give the patient corticosteroids because this is a very high risk disease where patients may develop blindness. So you give corticosteroids, you book the patient for temporal artery biopsy, you order the ESR, the CRP. Any delays can lead to vision loss. I think you guys should be taking this as a lecture either now or next year when you guys take the CVP block, the second one. And okay, let's see if there's any questions before we move on to the questions. How can we tell the difference between a hypertension headache and a tension headache? Great question, very good question. The answer is actually very simple. You take vitals. If a patient comes in with a tension headache, usually his vital is stable. Blood pressure should be normal. A patient with hypertension headache, the blood pressure is very elevated. Last week, I had a patient come in with headache. We did the vitals. Her blood pressure was 190. Another patient was 220. The way how you tell the difference is, one of them is patient has hypertension. The other one is just a tension headache. Shouldn't the bleeding be hyper intense under imaging? This is what, regarding which one? The subarachnoid hemorrhage, Isra, or something else? Okay. This is hyper intense. It's bright. Compare that with the surrounding tissue, right? You can see here, it's kind of gray, and here is kind of light gray. So in radiological terms, this is considered hyper-intense imaging or hyper-intense lesion. This is the classic star sign, by the way, of subarachnoid hemorrhage. It's like, you'll see it like accumulating across like the dural folds here, here, here. You will see, you might see elevated blood pressure in terms of stress. True, that's a good point. But hypertensive headaches usually happen. It's very unusual, by the way, clinically to see a patient with severe hypertension over 180. Hypertension headaches usually are going to be patients with a systolic blood pressure of 180, 190, 200. I saw 220. Last time I saw, like, the highest I've seen was 220. That is very high. Someone who's under stress, you might see elevated blood pressure 130, 140, but if it's above 180, this is a medical cause. I do not think any person will have a blood pressure over 180 that is non-pathological. But very good question. Anything else? Any question from like the whole topic, the whole lecture? Okay. Time for some good old questions. This is for you guys. The modulation of pain is controlled by which center of the brain? Is it A, periaqueductal gray matter? Is it B, interneurons? Is it C, Raphe nucleus? Or is it D, ventral medulla? All right. Okay. Easy question. Okay. Good job. Yes, it is A. It is the periaqueductal gray matter, and that's part of the pain modulation center. It is incredibly low yield. I have no idea why this is a previous question, but it is. All right. Question number 2. Woman comes into your clinic. She's been suffering from recurrent migraines for the past 6 to 7 months. Each episode lasts multiple hours. She is asking you, what drug should you give to prevent future migraine attacks? Okay. Anyone else? Any other options? Anyone think something else other than C? Oh, okay. Now we have a alternative point. So B or C. Okay. So can someone tell me why is it B, and can someone tell me why is it C? The guys or girls who chose C, why not B? And for the guy who chose B, why B? You can mute if you want, by the way. Okay. The correct answer is C. Yep, exactly. Ergotamines are abortive treatments. She doesn't have a headache at the moment, but she wants you to give her something that would prevent future migraine attacks. Sumatriptans and ergotamines are abortive medications. Paracetamol and diclofenac are not basically used for prophylactic treatment. So the correct answer is C, amitriptyline. Next question. A 30-year-old office worker started experiencing headaches, severe in nature, and impaired her ability to finish tasks at work. The headache is localized to the right side only, and the pain improves after sitting in a dark room. What is your diagnosis? Is it A, attention headache, B, cluster, C, migraine, or D, secondary headache? I think we have an overwhelming response for C, and you're absolutely correct. It is a classic picture of a migraine. She has photophobia, it is unilateral on one side, and severe enough that it's impacting her activities of daily living. Okay, next question. Which of the following is a red flag to secondary headaches? Is it A, tension headaches, B, headaches on one side of the head, C, headache relieving in the dark, or D, headache in the morning with vomiting? Okay, overwhelming response for D. My question is why? What is D supposed to represent? Why D? Yep, thank you. Exactly. A headache in the morning with vomiting is very kind of scary. I'm thinking of, I want to rule out increased intracranial pressure. If I told you a patient is coming in with a headache plus maybe fever, weakness, I'm thinking of infection. But in this case, a headache in the morning with vomiting, this is very specific for increased intracranial pressure. So absolutely correct. As you can see, by the way, guys, headache, the lecture looks scary. It is, inshallah, easy marks in exam. And most of the time, they only bring questions in the midterm. Expect 1 or 2 questions of headaches in the midterm, and maybe 1 or 2 questions in the final. Inshallah, all of you guys get all those questions easy. Does anyone have any questions regarding the topic? Any questions at all? I know I have a few questions, like 2 or 3 questions I did not know the answer to. I do not know who asked them because it's just 22. But you can always ask me. This is my my Twitter account. Inshallah, later on, like maybe around next week, I will upload like a 15-minute video of just the highest yield stuff for headaches. You could watch them 2-3 days before the exam. Yeah, something kind of. Okay, listen, guys. If you want the PowerPoint, sure. But let me tell you, 144 slides. And it's a keynote presentation, so it's going to be a PDF. I have no problem. Just message me on, I guess I'll send it to the PAL team. And if anyone has questions, this is my my Twitter handle. And hold on, I'll post my number here through WhatsApp if you just want to WhatsApp me. If you have any questions regarding this topic or any questions about neuro, just hit me up. I love to teach. I love to explain, especially harder topics. Headache is not too hard, honestly. I feel like it's an easy topic. It's annoying. To be honest, by the way, once you guys rotate in neurology, they have something called the headache clinic. If you're unlucky, you're going to be assigned to the headache clinic. I personally found this like the most, I'm going to say boring, but I'm going to say boring. Okay. It's a lot of patients who come in with chronic headaches. I think most neurologists, they do not like headache. It's their worst. Each specialty has that one chief complaint that everyone despises. I think for neurology, it's probably headache. But otherwise, hope you guys found the session helpful. Yeah, that's pretty much it on Saturn.